I think that's a good segue to the clinical discussion. So give me one answer for your preferred regimen for deletion 17p high risk. Is there such an answer?
You mean for newly diagnosed or in relapse?
For relapse. So we have a relapse patient. Is there one right answer? What's your?
I don't think there's a right answer. I mean, in this case, I probably would have gone with carpom dex because that would be drugs that the patient had not been exposed to. I don't think any patient should go through a million lines and not have seen carfilzomib at some point. So that would
just to clarify, if you're going, she got VRD, no transplant, no maintenance, and then DRD. So you're saying at the point of progression on DRD, you would go to KPD?
Probably. I mean, that would have been on one of my lists. Or clinical trial, of course, is always a right answer. But she hadn't seen those two drugs, so I would consider that.
And do you consider the deletion 17p in your decision making?
Yes and no. I mean, on the one hand, you have to be practical, right? You have to think of drugs the patient hasn't had. On the other hand, you have to consider why this evolution happened, whether it's truly a new clone or a clonal expansion. I think one other possible explanation is sometimes people have their marrows done at different places, and those can lead to different techniques and different findings. But she's presenting in a sort of high-risk way or aggressive way, so I probably believe it. Whether it impacts the decision is difficult because we really don't know the true, prognostic indication of, or prognostic significance of the high risk in comparing the different salvage regimens. That's really not been looked at and not prospectively for sure.
And just to go back a sec, would you have picked, what's your go-to regimen for first relapse?
So this is a very interesting thing because she didn't have the Rev maintenance. So I think that was a fair answer. I'd probably either DARA RD or KRD would have been a good option for her. That's probably what I would have done, one of those two.
And if she'd been on Len maintenance, Ola, what would you have done if she had been on Len maintenance?
So if she had been on lenalidomide maintenance and presented the way we have the presentation right now, I think I would agree with Nina's suggestion to choose carfilzomib pomalidomide dex. And just to add a few details why I would do that. So we see that the monoclonal protein went from 0.6 to 1.7 grams per deciliter in just 6 months. We also know that there is evidence of multiple lytic lesions by imaging. So there is a rapid progression of the protein, there are new bone destructions. And then with the bone marrow, we don't know how many cells there are actually in the bone marrow, but we know now that there is a new finding here with 17p in half the detected cells. So everything here unfortunately breeds a little bit of an aggressive biology. So I think for that reason I would do a proteasome inhibitor, and carfilzomib is the more powerful of all the ones we have. Given that she has received, in your example now, Revlimid maintenance, even if she was not, she was on DARA Rev Dex in this other example, so both those would contain Revlimid. So that would be the reason I would pick pomalidomide.
So I'm curious if I may ask, because I would agree with you. I think KPD, in the example as written, if she got DRD as first relapse, KPD is a good example. But interestingly, we just covered all the phase 3 studies, of which KPD is not one of them. Right. So do you practice evidence-based medicine? How important is it to have a phase 3 study? I mean, we're all at the academic medical centers, but what would you tell the community doctor? Do you need phase 3 study? How do you deal with insurance reimbursement? How does this all matter?
Well, that's a really tough question because there's not going to be a trial of carpom dex versus darapom dex. These things are not going to happen, and so we have to take our best guess. And when it comes to large phase 3 studies which have a definitive patient population, in these first 1 to 3 prior lines or newly diagnosed, you can really point to it. But as you get far off in the disease, how many more lines people have had, each patient becomes more individual. And I think it's hard to say phase 3 data is the end all be all of everything because your patient is never going to be that average patient in that particular trial. So I feel comfortable based on phase 2 data recommending things like carpom dex and darapom dex. How do you feel?
Well, I do think it's a reflection of the fact that the field is moving very fast forward, and it takes a lot of time to generate phase 3 data. In oncology, including both solid tumors and hematologic malignancies, many of the drugs that are being prescribed are not backed up by phase 3 data. It happens every day, everywhere around the world. It happens all the time. I think if you look at myeloma specifically in the United States, 90 to 95% of all patients diagnosed with myeloma are treated by a private practice doctor. And I think the newly diagnosed patients, probably the first relapse, maybe even the second relapse, many times can be treated with these data that comes from phase 3 trials. But after that, it gets more and more complicated. And that's why we use the NCCN guideline recommendations, and that's how we can also get reimbursement. And I think all the comprehensive cancer centers are using that all the time because we have a lot of these patients. They are usually referred to us. So I think that's kind of how that works.
Yeah, so I think this is a great discussion of the complexity of dealing with relapse disease. This was a very high-risk patient who had a very early relapse and even a very short remission on DRD, less than a year, and probably reflecting this high clonal burden of 17p deletion. And probably there is no one right answer, right? At the end of the day, treatment always depends on patient factors, disease factors, and in particularly in the relapse setting, prior therapies. So thank you all for this very interesting discussion, and we hope this was very helpful.